Should I start?
Yeah. Good afternoon, everyone. I am Ada Afshin on behalf of IGCB. I warmly welcome to all our respected doctors and participants for today's digital academic session. Today's topic addresses a silent yet critical challenge in hepatology, the quiet crisis, infections driving death in cirrhosis. In patients with cirrhosis, infections often as tipping points, precipitating acute decompensation, organ failure, and significantly increasing mortality. Early recognition, timely intervention, and preventive strategies can dramatically alter outcomes. This session aims to highlight practical clinical approaches to identifying and managing infections in patients before they become fatal. Introducing our speaker, it is my privilege to introduce our speaker, Dr. Vijay Kumar Rai sir. He did MD, DM in gastroenterology and liver specialist in Leave Gastro Centers in Kolkata. Dr. Rai brings an extensive clinical expertise in hepatology and advanced gastrointestinal care. His focused work in liver disease management makes him ideally suited to address this urgent clinically relevant issue. With great pleasure, I now hand over Dr. Vijay Kumar Rai sir to take us through today's session. Sir, this is over to you. You can proceed with the next. Thank you.
Thank you very much. First of all, I would like to thank for your warm welcome. Without much ado, I think we should start diving into the topic. Today topic is very interesting. It is a in this. Uh, I want to begin with the real world scenario we see too often. I have taken a case of 52-year-old man with alcohol-related cirrhosis, having a mild ascites, comes with confusion, no fever, no obvious infection, just worsening encephalopathy and rising creatinine. A cytic tapping was done, and that shows polymorphonucleoside count of 420, and within 72 hours, he developed septic shock, ACLF, and patient died. This is the reality, not varicose bleeding, no SCC, just infection. So, in cirrhosis, infection is often the event that pushes the patient over the edges. So, why this topic matters? Infections are not rare in cirrhosis. Up to 30 to 50% hospitalized cirrhotic patients they develop infections. Once infection occurs, mortality increases to 3 to 4 times, and one third may develop ACLF. So infection is not just another complication. It changes the trajectory of the disease. Now, question is why the infection is more important in cirrhotic patient than non-cirrhotic patients. So, in cirrhosis, there is a paradoxical immune state. On one side, there is immune deficiency, which is because of the decreased complement level, decreased opsonization, decreased neutrophil functions. Apart from that, there is another side. There is a systemic inflammation. So these patients are simultaneously immunocompromised and there is a hyperinflammation state. And that explains the infection are frequent and why organ failure progresses rapidly. Now, if you see the pathophysiology, there is a portal hypertension that causes gut wall edema and dysbiosis. And this increases bacterial translocation. Bacterial products they enter into the systemic circulation, they trigger inflammatory cascade, which causes circulatory dysfunction, which causes decreased perfusion of the kidney, renal failure, and ACLF. So the gut is the central to this event. If you see the epidemiology, the most common infection is spontaneous bacterial peritonitis. Apart from that, the UTI and pneumonia, they are also on the rise, apart from the soft tissue infection, skin infection, and the bacteremia. The what has changed over the decade is there's a rise in multi drug resistant organisms. There's a more healthcare associated infection, and there's an increased fungal infections in the ICU. So the infection profile is evolving. The difficult part is that the infection has a very silent presentation. This is very important clinically. Up to 40% patient may not have fever. Leukocytosis may be absent. So how can we recognize the infection at the early stage? Whenever the patient comes with sudden encephalopathy, there's a rising creatinine, patient is going to the AKI, there's a hypotension, there is a rise in the bilirubin. In that patients, you always suspect infections. Infection is also important as it's a trigger for ACLF. Infection is now the most common precipitant of ACLF. The mechanism is that whenever there is an infection, there is a cytokine storm, there is a circulatory collapse, there is a renal dysfunction, and there is a multi organ failure. ACLF grade 3 mortality approaches 70 to 80%. So, preventing infection progression means preventing ACLF. The most studied phenomenon is spontaneous bacterial peritonitis, which whose diagnosis is simple. If the counts is more than 250, the neutrophil count is more than 250, then it is diagnosed as SPP. Culture may be negative, but treatment should not wait for the culture. Organisms are shifting toward resistant gram negative infections. When the earlier antibiotic that give may not be effective at this stage. So we will discuss about this in the further slides. Now, what is the SPP practical protocol? There are three golden rules in SPP. The first is tap the ascites within 6 hours of admission. Delay increases mortality. And start antibiotic immediately after sending the acidic fluid for culture and biochemical and hematological analysis, and then start albumin at that moment only. Albumin is not optional. It prevents and it prevents renal failure and improves survival. In nosocomial setting, always consider MDR risk. After the SPP, the next infection is UTI. UTI is often asymptomatic. Many are ESBL producing organisms, so blind fluoroquinolone is not going to help. Culture guided therapy is important because many of these organisms they are ESBL, that is the extended spectrum uh, beta lactamase inhibitors. Next infection is the pneumonia. So aspiration is common due to encephalopathy and sarcopenia. Hypoxia worsens circulatory dysfunction. Do not delay ICU referral if oxygen requirement increases. Pulmonary infection can quickly destabilize these patients. After this, the next infection is skin and soft tissue infection. These infections are very aggressive in cirrhosis. They are often gram negative and polymicrobial. Any cellulitis in cirrhosis should be taken very seriously and especially watch for necrotizing fasciitis. Next is the sepsis in cirrhosis. Q SOFA may not perform well in cirrhosis, and fluid management is tricky because the excess fluid it worsens the ascites and pulmonary edema. So always try to maintain mean arterial pressure above 65 and accordingly titrate the fluid. Better to give albumin along with fluid so that the total volume of fluid will be lesser. The early vasopressor are often better than aggressive fluids. Next is the MDR crisis. In India, MDR organisms are a major challenge. Risk factors are recent admissions, prior antibiotics, long-term norfloxacin, and ICU stay. Carbapenems are being overused, but sometimes it is unavoidable. We must use local antibiogram to decide the antibiotic in MDR cases. Next is when to suspect fungal infections. Whenever there is no improvement in 48 to 72 hours after giving antibiotic, always think of fungal infection, because fungal infection have very high mortality, especially in ACLF, ICU, and recurrent sepsis. So in this patient, early echinocandins may save life. Next is the antibiotic stewardship. We must balance early treatment with rational use, start early but de-escalate when cultures return. Prolonged unnecessary antibiotic increases MDR crisis. Next is the albumin. Albumin is not just a volume expander. It improves circulatory function, it reduces inflammations, it prevents hepatorenal syndrome. Underuse of albumin is a common mistake. So never hesitate to give albumin, especially in patients of infections. Now I'm going to give a infection screening checklist in the patient of cirrhosis. For every decompensated cirrhotic patient, do a cytic tap, urine culture, blood culture, chest X-ray. And if the patient comes with encephalopathy, do not assume that it is encephalopathy. It can be due to sepsis. Next is the ICU. What are the important thing when the patient is in ICU? In ICU, the early source control is very important. What is the source of infection? Is it abscess, is it pneumonic patch, or collections are there? Avoid nephrotoxin drugs because circulatory dysfunction further aggravates the kidney function in cirrhotic patients. Start RRT early if needed, and nutritional support is very, very critical. Delayed ICU transfer worsens the outcomes. Next is the primary SPP prophylaxis. If there is a cytic protein less than 1.5 and there is advanced disease, then primary prophylaxis is recommended, otherwise not. Secondary prophylaxis, when patient had SPP already, in those patients we give the secondary prophylaxis, and this prophylaxis is lifelong. All the patients should be vaccinated for influenza, pneumococcal, HAV, HBV, and the Shingrix. If you see the economic burden, there is a infection that whenever the cirrhotic patient have infection, it doubles the hospital stay, increases the ICU cost. There's a chance of readmission, and that all leads to financial toxicity. What are the mistakes that we make in the patients who are coming with the infection? First is the delayed paracentesis. We do not check the ascitic fluid for SVP and other infection. We are waiting for fever to confirm there is an infection. So there's a blind fluoroquinolone use, thinking that it may work, but it actually not. Not giving albumin in case of infection, and ignoring MDR risk. The golden rules is always remember only five important things. First is suspect early, tap early, start antibiotic early, give albumin, and think MDR. So this is algorithm where always suspect infection, any cirrhosis, who are coming with worsening encephalopathy, hypotension, recent GI bleed, AKI, rising bilirubin, hospital admissions in the past, perform diagnostic paracentesis within 6 hours, no antibiotic in last 3 months, no recent stay, CRP, PCT. So blood culture, urine culture, chest X-ray, CRP, PCT, all have discussed. If there is a low MDR risk, then continue antibiotic. You can start with the cefoperazone sulbactam. If there is a possibility of high MDR, then you can start with meropenem and teicoplanin. And if there's a patient who are suspecting that it can be CRE resistant, like carbapenem resistance, you are thinking that meropenem will not work, in that cases you can start with ceftazidime plus avivectam plus minus azthromycin. Always keep the MAP above 65, and there whenever you find that MAP is down, rising lactate is high, progressive AKI is there, ACLF development is there, shift the patient to the ICU. Now back to the case. So, could this patient be survived? That we have discussed this patient possibility. Yes, if there is early suspicion, early escalation, early ICU support, it may have changed the trajectory of the patient, fate of the patient. So this is why this is very important. This is a crisis. This is an emergency. So the take-home message is that in cirrhosis, infection is not a minor complication; it is a medical emergency, and early action determines survivals. So with this, I close my presentation. I welcome you all for any questions. I'm happy to.
Yes, sir. Thank you so much, sir, for this wonderful session, sir. With all your permission, sir, shall I take question one by one?
Yeah, you can.
Okay. So the first question, sir, we see, sir, what are the most common infections seen in uh, patients and why are they associated with such high mortality?
Yeah. So infections that I have discussed, it can be SPP, it can be UTI, it can be pneumonia or LRTI, skin and soft tissue infections. So these are the infections that are most commonly happens in cirrhotic patients. Why this is more detrimental in cirrhotic patient is that cirrhotic patient they have immune paralysis, like there's a immune dysfunction, the neutrophil defect is there, the cytokine, the this complement level is low. There's a decreased opsonization. Moreover, there is a leaky gut. That the gut is totally edematous because of the portal hypertension, and that allows the easy access of the bacterial translocation and bacterial products. That aggravates the systemic vasodilatation, which causes the decreased perfusion of kidney. There's an increased activation of renin, angiotensin, aldosterone system. All these leads to overall there's a hypoperfusion state in spite of having high volume in the entire body. So all this leads to circulatory dysfunction, and finally the patient leads to multi-organ failure. So in cirrhosis, early recognition of infection is very, very important.
Okay, thank you so much, sir, for this brief answer, sir. So the next question I can see, sir, how can clinician differentiate early infections from baseline inflammatory changes in decompensated cirrhosis?
Please repeat this question again. How?
How can clinicians differentiate early infection from baseline inflammatory changes in decompensated cirrhosis?
So whenever the like uh, whenever the patient comes to you and there is a you are seeing that the patient is deteriorating, like he's in encephalopathy, he's having creatinine is high, and his BP is going down, then you can suspect that it may be infection. In that patient, you if there is ascites, you take the sample of the ascites, send for the culture, you send blood culture, you do chest x-ray, you send for the urine test and see the result. And if the patient is not improving, you empirically start antibiotic. So
Okay.
that is the thing we can do. And then once we get the culture report and the patient is improving, you can de-escalate the antibiotic. You can even stop the antibiotic also.
Okay, thank you so much, sir, for this brief answer, sir. So the next question is, sir, what is the current role of prophyla- prophylactic antibiotics in preventing infections such as SBP?
Yeah. So there are two types of prevention. One is the primary prophylaxis and one is the secondary prophylaxis. Primary prophylaxis means when the patient is not having any episode of SVP. In those patients, you do the ascitic fluid analysis, and if the ascitic fluid protein, total protein is less than one, the albumin is less than 1.5, then these type of patients are very prone to infection. In these type of patients, you can start the primary prophylaxis with norfloxacin. But in those patients who already had SPP in the past, in those infections, we start the secondary prophylaxis and we have to continue norfloxacin 400 milligram OD indefinitely.
Okay, thank you so much for this answer, sir. So the next question is, sir, how important is early sepsis screening and aggressive management in improving survival outcomes in cirrhotic patients?
Yeah. Like we have discussed in detail, that early recognition of infection is very important because once the infection sets in, then it is very difficult to treat the patients, to take the patient out, because there is a 3 to 4 times increased chance of mortality. There is a 30% chance of patient going into the ACLF. So early recognition of sepsis, early suspicion of infection is very important, and you start appropriate measures within 6 hours of admission of the patient.
Okay, thank you so much, sir. With all your permission, sir, shall I conclude the session, sir?
Yeah, you can.
Okay. Thank you so much, Dr. Vijay Kumar, sir, for such an insightful and clinically practical session, sir. Your discussion has clearly highlighted how infections in cirrhosis are often underestimated, yet potentially preventable causes of mortality. The practical guidance shared today will certainly help improve early detection and timely management in everyday practice, sir. On behalf of IGCP, sir, I sincerely thank you to all our participants for joining us and being a part of this important academic exchange. Thank you, everyone. Wishing you a productive and healthy day ahead, sir. Thank you so much, sir.
Thank you.